Hi, and thank you all for joining us today. I'm Ladan Ahmadi, and on behalf of Third Way, we're thrilled to be hosting this event on COVID vaccine disparities and building trust in the Black community. This event is part of a larger body of work that Third Way has undertaken on health disparities, racial justice, and economic opportunity for Black Americans. Joining me for this discussion is Dr. Rana Hogarth and LaShyra Nolan, who I will introduce in just a minute. Before I dive in, I just want to center the conversation and provide a quick State of the Union on where we are in terms of the vaccine with three quick facts. The first fact is, thanks to the Biden administration, we have administered more than 100 million vaccines, and hopefully all Americans over the age of 16 will be eligible by May 1st nationwide. Nearly a third of Americans have received at least one coronavirus vaccine. And on average, nearly 3 million people are receiving shots daily. That's up from 2 million in early March. Fact number 2, Black Americans are twice as likely as white Americans to get COVID-19, almost 3 times as likely to be hospitalized, almost twice as likely to die from it, and less likely to have been vaccinated. Fact number 3, in recent polling done by Kaiser, we've seen Americans are growing more enthusiastic about being vaccinated, with the most positive change in Black Americans. About 55% of Black adults have said they have been vaccinated or plan to be soon. That's up 14 percentage points from February. So this last point is one that we're going to spend some time exploring as we discuss the legacy of vaccine hesitancy within this community and what it means in today's context. So here's how our discussion is going to go. First, we'll talk about why there is vaccine skepticism in the Black community. Then we'll talk about disparities in access as vaccine rollout ramps up. And finally, we'll talk about what the government, community leaders, the medical community, and others can do to mitigate these issues now and in the future. After our discussion, we'll open it up to questions from the audience. So at any time, starting right now, feel free to type in your question into the chat function. So without further ado, I'd like to briefly introduce Dr. Rana Hogarth, Associate Professor at the University of Illinois, Urbana-Champaign. Dr. Hogarth's research focuses on the medical and scientific constructions of race during the era of slavery and beyond. Hi, Professor Hogarth, thank you for joining us. And we also have with us LaShyra Nolan, a second-year medical student at Harvard Medical School and the first Black woman to serve as Student Council President. Thank you both for joining us today, and we can just dive right in. Professor Hogarth, I'd love to start with you. I'd really like to spend a little time talking about the history of distrust and skepticism among the Black community for the medical community. Most of us now know about or have at least heard about the US Public Health Service syphilis study at Tuskegee, but there's much more to the story than just that. Could you tell us a little bit more about this history?
Sure, absolutely. So thanks very much for inviting me to be part of the conversation. And yes, to this first point, a lot of us have heard of Tuskegee, and it makes sense. It's sort of one of the worst ethical breaches we know of. It's one of the longest non-therapeutic trials out there, but it's actually not the beginning of this kind of exploitative and predatory regard for Black people's bodies. I will say that based on my research, you can go as far back as, the 18th century to see a medical regard for Black people's bodies that's premised on an idea of Black people being peculiar or other. So for example, assumptions that Black people were less sensitive to pain is something that one can trace in 18th century medical treatises. Assumptions that Black people are immune to certain diseases or don't suffer as badly as whites from certain diseases. And again, this is something that well-respected, highly regarded white physicians believed and circulated amongst themselves in medical writings. So this idea that Black people were always different, that their bodies were other and peculiar, is something that is kind of deeply entrenched in a lot of medical knowledge from the past. So, when we think about Tuskegee, we can say, obviously, this is unethical, but we ought to make sure that we understand that one of the racist premises of the study was that syphilis was going to appear to be a different disease in Black people than white people. And that is actually old logic. The idea that diseases might run a different course, that Black people's bodies are different and other, is something that has been around for quite some time. So really, when people say, okay, this reminds me of Tuskegee, or Tuskegee is the time when the government treated Black people in this way, I would say, yes, it makes sense to think about Tuskegee, but we're looking at something that's much deeper, much longer, thinking about medical schools, disproportionately relying on the bodies of African Americans in the South for dissection. At a time when nobody wanted to be dissected, medical schools are literally preying upon Black people, targeting African American cemeteries. When we think about, this notion of pain insensitivity, that 2016 study that came out that said, there's racial bias in pain treatment, and the idea that, residents might hold some peculiar views that Black people have thicker skin, that's not really surprising for historians of medicine who study this, because we know we can look at, the 1780s and find a treatise that says, oh, well, Black people seem to bear surgeries better than whites. This idea that they have, more robust, or more tolerance for pain. So really, for me, I see this conversation as one that might perhaps lead to a bigger reckoning with the history of racism within medicine, in medical education and medical training.
Thank you. Lash, I'd love to bring you in here. Obviously, you're a medical student. What can physicians and others in the medical community do to not only acknowledge this history that Dr. Hogarth just, spoke about, but to build trust within this community that's gone through so much trauma?
Yeah, I think that everything that Dr. Hogarth has said is something that I've been trying to study a lot on, because it does impact the ways that patients understand and view the medical system. And I think that the way that we build trust is really this acknowledgement that the reason why the medical institution existed, the way that Black folks experienced the medical institution, was so that they were healthy enough to continue the oppression that they were experiencing. So the only reason why physicians wanted to care for those who were enslaved were so that they can continue to do the forced labor that they were being forced to do by folks who had enslaved them. So I think that an understanding that the medical institution has had that purpose from the very beginning, and then on top of that, the medical institution has been directly implicated in furthering oppression of Black people, whether it was Samuel Cartwright saying that Black folks wanting to escape slavery was drapetomania, and that was a mental illness, or the fact that we hold up figures like your Marion Sims for the contributions that he's made to obstetrics and gynecology, but all of those experiments that he did were on those who were enslaved women. So I think that those are the things that we really need to start thinking about in medicine, and having a true reckoning with the ways that the medical institution has harmed the Black community, and the ways that we continue to harm the Black community. I think that this conversation has been largely focused on, well, let's think about Tuskegee, let's think about things that have happened in the past, but I believe that it's the everyday racism that Black folks experience. If we think about maternal mortality rates, if we think about the fact that a lot of folks aren't even going to have I'm in Boston, and I'm near some of the greatest hospitals in our country, but not all patients have access to those spaces because their insurance not being accepted, or them not even wanting to enter those spaces because they know that they're going to experience racism, because those individuals have these preconceived notions about them. So I think that all of those things are things that have to be addressed if we really want to get to the root of trust. And I think that as soon as racism comes up, I think that people kind of shy away from it. And I don't think until we have a critical acknowledgement of the ways that racism has harmed our communities that we're going to really be able to build trust.
Mm-hmm. And just to dig into that just a little bit more, how have these health disparities and past failings by the U.S. health system contributed to these high rates of infection that we're seeing with COVID now? And Dr. Hogarth, I guess I'd like to start with you there.
Yeah, so I mean, I want to do two things just to sort of highlight something that Lash brought up that I really think we need to consider, is that idea of these spaces, right? These medical spaces, even renowned hospitals, and the fact that you might have minority populations that don't want to go into those spaces, right? And you might say, okay, how do we rectify this? And I can't help but think of the ways in which day-to-day, like routine interactions or things that we don't even question about, like medical cultures, can contribute to this. So for example, the idea of dismissing somebody's pain or assuming somebody's non-compliant or has a drug-seeking behavior when they go into an emergency room, turning people away. The issue, of course, bigger issues of insurance and not having the ability to pay. And that is something that those are the things that, communities of color confront. And just thinking about the idea of being at a place like in Boston where you have access to these amazing hospitals, and yet, that communities of color, Black people are not going to necessarily have access, is extremely problematic. And it's kind of frustrating, right? Especially from the historical standpoint, to think about, when you go into a clinical space, those are all of the overt issues to deal with. What if we start to ask questions about how things like race correction still exist in certain medical apparatuses, right? So you have the spirometer that has a race correction built into it. You have kidney function that has race correction built into it. All the while we're saying, oh, race is a social construction, or, oh, we treat you all the same, everybody's equal, but that still exists in medicine. So I just wanted to kind of just flag that for a moment, because, if we're talking about building trust, I do agree we have to talk about this like historically. And I really like the idea of focusing on now in the present and thinking about these moments in the clinical setting, right? That face-to-face where, you have physicians saying, well, no, of course, everybody is going to be treated equally. But then they will say, well, I'm going to add more points to your kidney function score because you're Black. And that's what the algorithm says to do. That needs to be sorted out if we actually are going to try and make more progress. And I think to the point of, some of the factors that are in place now, I can only sort of speak to sort of what's going on in Chicago, just like, what I've read about in terms of thinking about specifically South Side and West Side communities where, these are big systemic problems that are now coming up that people are choosing to notice now, in terms of the sense of no transportation, not enough pharmacies that are actually there to distribute like vaccines. So when they say we're going to roll out the vaccine and we're going to offer it to these major pharmacies, if you look and see which pharmacies have closed down and which pharmacies are actually available in minority communities, it's not the ones that are going to be able to offer the vaccine. If you think about, how am I going to get to the vaccine, get the vaccine, transportation now becomes an issue. So you're looking at like sort of infrastructure concerns, and then the basic issue of internet, which is sort of, oh, you just sign up online. If something like, 50% of communities in Englewood don't have internet access that's reliable, how on earth are those people who are, again, mostly minority, Black and brown people, how are they going to get access, to sign up for the vaccine? So I think that we are dealing with, unfortunately, both a problem of medical cultures around race, but also sort of larger infrastructure and issues of sort of histories of neglect, which is a hard thing. All of these are hard things to sort of overturn, but at least we can start talking about this and recognizing these problems. And maybe we can pinpoint each one of these things at the same time, rather than just, focusing on one thing.
I think you make wonderful points there. And just to add on, in terms of barriers to care, another, they're opening up all these mass vaccination sites, but, sometimes you're sitting in those lines for hours, and not everyone can take off work twice, in certain instances to do that on, a month apart. So that I totally understand. I think that that's a really important point. So just to take a slightly different angle here, we're talking a lot about access. And as you two both have mentioned, like this is mostly an access issue because as we've seen, hesitancy has gone down, especially in the Black community. So what's the danger in focusing too much on the distrust of Black people for the healthcare system rather than focusing on the untrustworthiness of the system? Like, I'd really like to talk a little bit more about that. Lash, do you have thoughts on that?
Yeah, definitely. And I'm so glad that we are talking about access because I think that if we frame the entire conversation, I think previously we were framing the entire conversation about Tuskegee. At least that's what a lot of what was coming out in the media. But we were missing the opportunity to improve the conditions of people today by focusing on the past. And I think by us kind of saying like, oh, that's something that happened back then that we're having to deal with now, we're not focusing on the now and the things that we can do to help mitigate harm. And I think the same can happen if we focus on this idea of hesitancy instead of access, because once again, by putting it on hesitancy, you're kind of making it seem like it's individual behaviors and thoughts that are preventing them from getting the vaccine, but really it's these systems. It's lack of access to the vaccine, lack of access via transportation, language barriers, essential worker status, right? When are these vaccines being offered? There's just so many things that we should be talking about that would improve the conditions of everybody in America. It would improve the conditions of healthcare access for everyone if we really focus on what are the issues with the system and how this rollout is happening that's causing unequal access to the vaccine for folks. And I think that that's something that really needs to be talked about, especially because when we think about who's truly hesitant at the moment, it's white Republican men, and no one is talking about that. You don't see these campaigns, or you don't see any papers coming about what is really going on with the mistrust of the government from this population. But when it comes to the Black community, we're so quick to throw out this word hesitancy, when really I think what it was is people were having deliberations. They were trying to figure out what information they needed to figure out, was this going to be the best decision for them? And I think considering the history of harm in our communities, it makes sense that people were taking their time. But we've seen that as they've taken that time to get more information and do that outreach, that they have come to the conclusion of realizing, okay, I think this is something that's going to be good for me and my community. But there's this other population that's been stagnant, and no one is really talking about that. And I think that's what we definitely should be focusing on. Is like, why is it that this group isn't moving, but really focusing on this access piece? Because I think that once we tackle that, it'll improve the rollout for everyone in America.
If I could just add as well, I mean, I think that this is a really great conversation on multiple levels, because I think that not only can we are seeing, right, this increase of African Americans and Black people getting the vaccine, which is really great news to hear. And I think the idea of saying, let's channel our energies into access to actually understanding problems as being systemic and deeper rather than something that's a quick fix. So it's one thing to say, okay, I'm going to explain what is in the vaccine. It's quite another thing to say, I'm organizing transportation and I'm going to make sure that you have access to this. We're going to do something about the fact that you don't have internet access, or we're going to do something to make sure that people don't have to take 3, 4, 5 buses just to get, their first round. And then how do they get the second? So I think it's great to have this conversation. I will say that it also, for me, I hope that this will be a moment that, let's hope everything goes well. We all have, we get to herd immunity, but the next time there is some sort of public health crisis, and we have this issue where we have minority populations kind of saying, okay, wait a minute, we're getting disproportionately affected or something is happening, that we start to have these bigger conversations that maybe change the entire profession of medicine and public health messaging. Because one thing that I do want to see happen sort of as a long-term, something that's sustainable, right? I would hate for there to have to be another public health crisis, and only then do we decide to have these conversations, where I think that right now is a good time to ensure that we are addressing systemic issues, that we are also not putting the burden on Black people to sort of say, oh, we need to convince you. I say we flip the conversation and say, okay, medical profession, public health officials, here's how you need to learn to listen and understand why in the first place we even had to deal with hesitancy, and why in the first place we even have this disproportionate issue. Because I think what we're seeing here is folks kind of saying, okay, well, we'll just convince these people. And I'm like, it's not about just convincing. You've got a whole reckoning to do with the profession of medicine, particularly to the idea of, how we use the term race. When people say, I don't want to go to the doctor, it's not because they don't understand doctors. It may be because they don't want to be disrespected. Or maybe because it's stressful to go into the doctor's office or into the emergency room. And that is something that hopefully we can seize upon this moment to have some of those really important discussions as to sort of how to stop this, how to make medicine and healthcare not about, okay, I fixed your problem and now you can go, more along the lines of, I care about your well-being and how do we handle your well-being? I think that's something that has been missing from a lot of conversations around minority health disparities.
Absolutely. LaShyra, I'm going to turn to you for this, just building off what Dr. Hogarth just said. I think this was super evident with the initial focus on, the whole goal of the vaccine rollout was to focus on people who were most at risk. But then we chose to vaccinate those who are 75 and older, and that left many Black people and other minority communities off of these eligibility requirements because they have, shorter life expectancies and other things. So can you talk a little bit more in specific about what we can do, the medical community could do specifically to actually reach those most at risk now that, eligibility requirements are opening up and we're talking about access?
Yeah, well, I think first, like there were a lot of folks who were coming out and they were saying, by just doing this by age, we're going to run into a problem because of the ways that racism impacts health and the way that life expectancies are going to be cut short. So I think that it can get confusing for people because they're just like, okay, so race is a social construct. You're saying that you don't want me to include it in different algorithms in medicine, but then you're also telling me to create a rollout that's race-based. So what is it? And I think the way that I think about it is that race is something that was created to justify racism, right? So as a result of that, we now have a system where we have folks who live in certain neighborhoods, have lower life expectancy because of the way that race was used to perpetuate this system of oppression known as racism. So I think that whenever we're looking at systems-wide problems and we're trying to look at the way the disease falls along the lines of certain zip codes or whatever challenges we're trying to address, we need to look at race because oftentimes things are delineated along race in our society because of racism. So I think that for that reason, it would have been really important for folks to consider race when they were thinking about who needed access to this vaccine because who was disproportionately impacted by COVID-19. And then when the question of access comes up, I think that we're thinking, all right, so we're just going to, as Dr. Hogarth was saying, we're going to just make sure that the vaccines are accessible via pharmacies. But then we have these pharmacy deserts, just like we have food deserts, where people don't have access to where the vaccines are being distributed. So I saw one paper that came out and they said that if we were to have vaccines distributed in dollar stores, then it would be a way for folks to have more access to it because of just the placement of where the dollar stores tend to be. So I think that people just need to think creatively. And I think that we really need to lean on community leaders and organizers and activists because they know their communities better than anyone else. And I think that we need to meet folks where they are. If we can get to a place where we're able to knock on folks' doors and do canvassing and vaccinate them right then and there, especially with the Johnson & Johnson vaccine, all you need is that one dose. I think that that could really be a game changer. But I think if we keep on expecting people to just come to us and we're not thinking about who has access after certain hours or who is going to experience some of those side effects, but not have the ability to take off that day of work. What are some policies around that we can make sure that, folks have that paid sick leave if they do have those fevers and chills the next day. So I think that those are some things that we should definitely start to think about. But I think that race is something that's going to be important for us to consider when we're thinking about access.
Yeah, absolutely. One of the other things I just recently saw was that they had set up this telephone line for folks to call to get vaccine appointments. But they said, they advertised it in all these different languages, but if English was your second language and you needed to access one of the other translated lines, when you would click the number, the call would just drop. It was like some sort of glitch in the system. And it's like, okay, we're going through the trouble of like translating and putting all these signs up and getting people to call. And then when they actually take the time to call, they're like not getting through. So like you said, thinking creatively and finding the way that you actually reach people is so important. Awesome. So I'd like to just, you mentioned Johnson & Johnson. So I want to just dig on that a little bit more. As you mentioned, logistically and practically, Johnson & Johnson vaccine could provide better, would be better for access and for the vulnerable communities because it's easier to store and transport. You only need one shot. You'd only have to take off one day of work. But one thing I've seen is that it could also drive perceptions of this two-tiered system along racial or class lines, with marginalized communities thinking they're getting like an inferior vaccine. how can we combat this idea and ensure those vulnerable communities, first of all, don't feel this way, and if they're eligible, they just go and get their vaccines?
I mean, I might just say messaging is so key right now. So absolutely this concern, right, about, which is the so-called lesser vaccine. So I keep seeing people saying, okay, this is 99 efficacy, 95%. And then they'll say, oh, but this is only 70 or 67. And so what I would say is, unless we've done an exact head-to-head comparison against all of the vaccines, which did not happen, because then we should stop doing this, because I think that's part of what's driving people to think, well, I want the Pfizer one. If that's the best one and it has 99 or so, that must mean it's better. But this one only says 85. Well, I don't want that one. And it's sort of like, I see these headlines about the percentages, and I wonder if there is a way, particularly those who are, whose job it is to do this kind of public health messaging, right? To make sure people understand what it means when you said that this is 85% or 87% efficacy in a clinical trial setting. How does this translate to you day to day? Like, what does this mean for your risk of hospitalization or having major, COVID-19 disease? Like, having that information be foregrounded so people understand that this is sort of what the performance was in a very specific setting, and this is for a completely different mechanism of vaccine. One is the single dose, that's sort of the traditional one. One is the mRNA vaccine. So people are doing these comparisons, and I'm thinking, oh no, I don't think this is how you compare these two things. And I'm not a virologist, I don't work in clinical trials, but I'm already saying, okay, maybe we need to not be doing these kinds of comparisons. So messaging sounds really like essential here, especially at this point of, we don't want to create this idea of second class, right? Second class citizenship, second class, not as good vaccine. That is just going to add to the problem. So I do think that, the idea of creativity is key. The idea of using race, particularly the idea of which groups of people are more likely to deal with racism and are more likely to have a lack of access because of their race. Like, knowing that and factoring that into any kind of program going forward, saying, okay, what is the zip code? What is the demographic breakdown? How do we sort of target and know what to do? But I think even before going into a neighborhood or saying, okay, we're gonna come in here to save the day, I think we should have time to make space and let people speak and listen. Like, as in to say, let them tell us what has been ailing them and say, this is what our problems are. If you want to come in here and help us for this one time, that's fine, but we want to see you committed all the time. Because I think that's part of the problem, where there's a flare up where people say, okay, we're going to look after you. We now see that there's a problem, and then people go away after, everything has died down. And I think what we need to see is sustained commitment to communities that have been, for generations neglected and sort of felt like second class citizens. So I'm a big, proponent of actually listening and letting community members and community leaders, people who are trusted, kind of steer the course and have them feel like they are partners in this, and not have it sort of be, we're just coming in, but have them say, we want to take control of this. How can we help you? I guess is the way to sort of frame it.
Yeah, and LaShyra, I know you're involved in actually doing that work in the Boston area. Do you want to talk a little bit about that and how you found reaching to the community and what success you've had there?
Yeah, definitely. So in December, after the vaccines were approved, I was getting a lot of calls from family members who were just like, is this right for me? I'm nervous about this. And I was able to have FaceTime calls, phone calls, texting with folks. And in that moment, I realized this great privilege that I had, being a Black woman from my community, and then also being a medical student, because I was able to understand the challenges that they were having, because I was having some of the same ones. But then I also understood the science. I also understood all the trials and all that information. So I was really able to be this conduit of information between my community and the medical institution. But then I realized that not everyone has that privilege. If you think about who are physicians in America, 2 to 3% of them are Black women. So that means that a lot of folks are being left out of conversations because they don't necessarily have someone who can relate to their experience. And there were studies that were coming out at the same time showing that racial ethnic concordance between practitioners and patients, it really mattered, because those patients were more willing to seek information about the vaccine if they received it from someone from their community. So that then led me to create this organization organization called We Got Us, and it's a community empowerment project, and it's a grassroots collective of Black community members, health professional students, pre-medical students. And basically what we do is we try to empower our community with information about COVID-19 and the vaccine, but we also work to increase their access to the vaccine as well. So primarily we do this through these empowerment sessions, and they're like these online 1-hour sessions where we talk about the history of medical racism. We talk about what vaccines are, how they work, some of the ones that many of us have taken, but maybe might have forgotten about. And we go into the details of all the trials and then finish up with a Q&A, like a family roundtable where people just kind of talk about things that are still on their minds after we have the session. And it's been really powerful because people have real concerns, and each group is different. We do these for churches and schools and really whoever requests for our team to come and speak to them. And I think that in talking about the different types of vaccines, it's really important to break down like what's the difference between efficacy and outcomes, and how people who create studies, they get to decide what those things will be. And I always end by saying the best vaccine is whichever one is available to you and is in your arm, because they are all 100% effective in preventing severe disease and hospitalization. But really breaking down like, what does this efficacy thing mean? And how does that differentiate between the different trials? And I think that sometimes different news reports like that, to make things more palpable, like they'll just kind of cut corners, but that can be really dangerous because it leaves people with questions. So I think that what we're trying to do is really explain the nitty-gritty science in a way that's really getting to the community in the way that's helpful for them, and making sure that we're not saying, oh, we're gonna like dumb it down because we don't think that they'll understand this. And I think that that could be a really bad thing that folks can do. And it's just not the best way to go about it. So I think making sure that folks have all the information and details that they need, and then allowing them to then decide what questions they have after that is the best way to go. And that's been the power of these empowerment sessions.
That's amazing. I think that's totally right. And also, we've seen the Biden administration sort of, invest in community health centers. And last week they announced a new campaign to combat vaccine hesitancy. And they've partnered with, I think it's 275 local organizations all across the country that do this work already and are trusted messengers in the communities, which I think is a great step. I've also seen another organization run by Valerie Jarrett. They announced today they're going to run an education campaign to reach some of these communities. But so obviously the work that you're doing in your community is key because you're there, you're embedded in that community, you're trusted. But how successful do you think campaigns like this coming from like the federal level can be or are? And what else should the Biden administration be doing to reach these people?
I mean, it's a tricky one, right? Because I think the idea of building trust is something that takes time. And I do think that the idea of sort of having sort of a top-down sort of people just coming in and saying, okay, we were sent here by the government to help, that can maybe not necessarily do the work you want it to do, right? So I think that if there is a better way of saying, we have been talking to people in the community, we are trying to listen and gather information from you of how we should move forward. In fact, having sort of like town halls, or whether they be virtual, where people can say, these are our concerns. So we're bringing you our agenda. Now, can you act on the agenda? So kind of having it be, as I said, more of a partnership, because I do fear, in some cases, somebody that you don't know, right, shows up and says, okay, I'm here to offer a vaccine. Here's a pamphlet. It's like, well, I don't know who you are. You've just kind of shown up, and you know what, I'm going to pass. Like, it's easy to envision a circumstance where somebody in a community where it's like, you haven't been here before, and now you've just shown up, and now I'm just supposed to drop what I'm doing, take this pamphlet and just trust you, person that I don't know. I think we want to avoid that circumstance. And so I think, again, it's the burden on saying, you should just take my word for it. And I think that that's what we want to avoid. So I definitely think having more local community driven approaches where you have a rapport, right? Where you feel like you can trust the person. And even, I'm not saying that that's like a magic wand, but at least you're starting that with the sense of, we're giving you information. We want to hear what works for you. And we're talking to you as, a member of the community, that we're invested in this too. Because at the end of the day, the person from outside is just going to leave. You're like, okay, I came to do my thing, I'm out. So we have to really be realistic, I think, with any kind of, policy or program going forward, to say that it's great, the intention is there, it's awesome, but you have to think more creatively and more long-term about the contours and landscape of the communities that you want to serve. And I think to do that, that means the onus is on you to build trust. And I think that means spending a lot of time listening and a lot of time investing in community leaders, and sort of allowing community leaders to sort of to take the reins, I guess, in a way, and to have trusted people be a part of this. So it's great to hear of these initiatives, by the way. I'm not saying not to do that, but it's just about how to make sure it's effective and sustainable.
Lash, did you want to add anything else there?
Yeah, and I 100% agree. I think that the sustainability piece is really important, because we're supporting all of these community organizers and groups now because it's expedient for us. Like, we want to get to that herd immunity. But what happens 1 year, 2 years down the line when these same community organizers and groups are trying to empower their communities with whatever other initiatives and projects they've been working on for years without any government support? So I think that we need to make sure that we're still going to support communities and uplifting them beyond just this moment, because I think it could be a really bad look if, suddenly we pull together billions in funding, but then all of a sudden, once we get to that herd immunity, we step back. Because I think that the reason why we're in a lot of the spaces and challenges that we are today is because we did not fund public health infrastructure appropriately. I think that we didn't think about using community organizers and using community health workers. And I think that if we can kind of use the infrastructure that's being set in this moment and continue to build on that in the future, and continue to really trust on these trusted messengers in the community to help us do this work, it could be really powerful. But if we kind of just put all of our eggs in one basket and then retract them later on, once we've kind of gotten what we wanted, it's not going to be good for future partnerships or sustainability for the safety and health of communities.
Absolutely. That's a great point. I could talk to you ladies maybe for another hour, but I know we're coming to the close. So I want to make sure we get to audience questions. So I'll just ask one more before we get to the audience. I don't want you guys to feel like you're repeating yourself, but a lot of people watching today work on health policy. They're working in Congress. They work maybe in the executive branch or nonprofits in DC. What's one thing you would want them to take away from this panel? And Lash, I can start with you there.
Yeah, well, first I'll say thank y'all so much for spending time with us today. I hope that we focus on access. I think that the education piece, even with We Got Us, the project that we've been working on, the empowerment sessions is just a component of the work that we do. We're out in the community door knocking with iPads, getting people registered, giving them Uber vouchers and taxi vouchers to physically get to vaccination sites. And I think that it has to be coupled. Like, we have to do that education piece, and then we also have to do that access piece, because I think that the two go together. And I think if we can continue to push on leaders to make sure that folks have access to this vaccine, we'll really be able to get us steps closer to exiting this pandemic. So I think that that's something that I really wanted to drive home today.
I would basically second this approach. I think absolutely putting in place sort of sustainable measures for access. I also think that, to tackle something like this, so just in the case of COVID, but I think moving forward, any kind of issue around racial disparities, you need to have access. But I also am a strong advocate for trying to sort of push back and change the cultures of sort of how business is conducted in sort of the medical establishment. So I am all about this idea of sort of concordance with, patient and practitioner, I think is extremely important. I think in terms of understanding how there are subtle and maybe, unknown or implicit ways that practitioners or healthcare providers might actually be doing more harm than good in terms of how they talk to patients of color, that needs to be addressed. So I think that in terms of policy going forward, there's education, not necessarily just for the community, but I think actually for healthcare practitioners. I'm not talking about a cultural sensitivity workshop. I'm actually talking about sitting down and looking at pages of JAMA or New England Journal of Medicine and saying, okay, we need to understand how we have been deploying concepts of racial difference, or how we have been talking about race every day amongst ourselves, and how is that, negatively impacting our patient populations. I think there needs to be a serious reckoning with the idea of, hospitals where they're sort of the teaching hospital, where you have, practitioners who are there to learn, to teach, and then they go home to their own neighborhoods and they're not a part of that community, and sort of how to address that, because I think that's a problem in terms of trust, and sort of how do I feel as a person going into this healthcare establishment. So I certainly think that access is key, sustainable outreach within communities, but centering community leaders, but then certainly understanding education for both practitioners, for members of the community at large, and then having really candid and sometimes hard conversations about the legacy of racism in medicine and public health is certainly something that needs to happen.
Thank you. We're running a little low on time, so I'd love to get an audience question in. Here, someone submitted a question that says, I agree that empowerment session is invaluable for the community. Is there a social media model that can be implemented? Lash, why don't we start with you on that?
Yeah, so I actually reached out to this person and told them to email us, so we got us. But yeah, I think that the social media model would definitely be effective, especially because it seems that a lot of folks between the ages of 18 and 35 have been among the most reluctant to get the vaccine because of concerns that they have, or because they're like, I'm young, I don't need this, my grandparents got it, so I'm good. So I think that there's like a lot of messaging and things that we have to think about. So I think that social media would be super effective, but I always go back to this idea that Black people in particular, like, we're not a monolith. And I think that each of us are in different communities and different organizations and different activities. So we have to really think about, if we're going to use social media, how do we make sure that we're addressing that particular group and making sure that they're receiving what they need? Because it might not necessarily be an empowerment session. It might be reaching out to community stakeholders and letting them know, like, hey, like, this person is someone who really supports this, and these are the reasons why they decide to make this decision, and kind of doing it that way. So I think that we can definitely leverage social media, but I think that it will definitely have to be a little bit of everything.
Dr. Hogarth, is there anything you wanted to add there?
I mean, I would both basically second what Lash has said. I mean, I think that, being targeted and understanding, I really do appreciate the acknowledgement that, yeah, there are multiple different kinds of Black communities and communities of color. So recognizing that and sort of targeting and tailoring any kind of message, whether it be social media or otherwise, is essential.
Awesome. I'm just going to get to one more. I know we're getting to the end here. Someone asked, do you agree that workplace vaccination clinics for essential workers could help close the gap in vaccination rates for minority communities? Either one of you, if you guys have thoughts on that, would love to hear it.
No, go ahead.
Yeah, I think that it would be effective. I think it would definitely help us address the issue of access. But I do think it's one of those situations where we have to make sure that the information and the education piece, like making sure that everyone gets their questions answered, gets their concerns addressed. And it's not like a coercive thing. Like, I wouldn't want it to be like, you come into work, so you have to get vaccinated. I think that the messaging, and then making sure that people have space to make the best decision for themselves, having multiple opportunities, like not making it like a one and done, like, oh, you didn't get it when we were there that one day, so therefore you've lost your opportunity. But I think that it can definitely be effective in addressing the access piece, but making sure that we think about the messaging and the way that might look and the way that people might feel in that space as well is important.
Thank you. Dr. Hogarth, anything to add?
Yeah, I mean, I would just say that just being careful about the optics at workplace, right? So just to make sure that, one, did you fully sort of vet this information with the employees? Did you give them an opportunity to say, okay, here's a question and answer session over multiple times for you to sort of air out any concerns you have when we launch this, and then make sure that people aren't sort of using it in a way to say, well, you didn't get your vaccine. And that could cause, more stress and tension in the workplace setting. So it sounds great on paper, but I think you would have to really be careful in terms of the optics, the messaging, and then making sure you have full buy-in and flexibility for those who are at work.
Thank you. I'm going to be conscious of everyone's time here. Thank you both so much for joining us today. This was incredibly informative and important. Hopefully we can do something else like this once we're sort of over this next hump in terms of vaccine rollout. So a special thank you on behalf of Third Way, and to everyone who joined us. Thank you so much for tuning in. I hope you guys have a great day. Thank you.
Thank you.
Thank you.